Hi, Dr. Carolina. You can try your microphone and audio and also try to share your poster as a test.
Shall I share the poster or preferably the PowerPoint? What do you think?
I think you can do both. Anything.
Okay,
Yeah.
Let's see what works. And hello, good morning. I'm a little bit okay. Is this clear or?
Yeah, clear. We can see it clearly. Yeah, perfect. Thank you.
Yeah, you're welcome. I'm a bit nervous actually, so.
Very good morning, Carolina. I think your presentation, it's time. Shall we start the presentation?
Okay.
Yes.
I think should we have to wait for other people?
No, we need to start the presentation on time. We need to wait.
Yeah, it's 10:55 in Indonesia, so 5 minutes?
Yeah, it's 5 minutes.
5 more minutes?
Yeah, 5 more minutes to the
possibly.
Okay.
Yeah, thank you. Another presenter coming in. Dr. Palini, can you try your audio and try to share your poster as a test? Dr. Palini, can you hear me?
Yes.
This is a test before the presentation. You can try your audio microphone and sharing the screen.
Okay. Can you hear me?
I barely hear you. And anybody else can hear Dr. Palini?
I can't hear her either.
Dr. Gracia can hear Dr. Palini clearly, right?
No, I cannot.
Yeah,
I can
yeah, your voice very low.
Okay, I will try again.
Oh yeah, this is better.
Okay.
Thank you, Dr. Nipaporn.
And do you also want to try to share the poster?
Yes.
Okay, you can say it.
This is the full screen or not?
No, it's not the full screen.
How can I show full screen?
Anyone use a PDF file as a poster? How can you make it bigger?
Dr. Palini, there maybe, yeah, you figured it out. Out.
Okay.
Just press on the plus.
Thank you.
And this is the full you please
It's still not a full screen, but it's a little bit bigger.
Oh, it's not a full screen. How can I present the full screen if I use the PDF? I don't know.
Mr. Technical Team, can you help with this? How can she present it as a full screen?
Should I use the PowerPoint file, is it better?
Yeah, I think so because it can be presented at full screen.
Okay.
Now it's 11. Oh, sorry, it's 12 in at Hong Kong time. Sorry. I think we should start.
1 minute, ma'am, please.
Oh, okay. 1 more minute.
Excuse me if I want to share again, please.
Yeah, you can try now.
Is it better? Is it full screen?
It's actually it's not full screen, but I think we can read it. Yeah.
Okay.
Anybody agree with it?
I think it's clear. Yeah, it's clear.
Yeah, I think we can
It's
read
nice.
it clearly. Yeah.
Okay, thank you. Thank you, everyone.
And we have the same background.
Now we are live, ma'am.
Okay, good morning, good afternoon, everyone. Welcome to the poster presentations of Behavioral and Epidemiologics and Health Services Research 2. Our presenter we have 11 presenter. Each presenter we have 3-minute presentations and 2 minutes Q&A. Now let's start with the first presentation. Dr. Carolina Mapwang from the University of Trisakti. Yeah.
Hello. Shall I start? Yeah.
Yeah.
Yeah. Okay.
Share the screen.
I can share. I think it's better if I do this. And sorry, and this. I think everybody can see.
Yes.
Yes. This is hello. Good morning. Or afternoon. My name is Carolina Marpao, together with Professor Adrian Yap from Trisakti University. We conducted a research entitled "The Interrelationships Between TMD Severity, TMD as Temporomandibular Disorders Severity, Emotional Distress, and this is quite difficult, eudaimonic well-being." Okay, it's been known that temporomandibular disorders, or TMD, are common among young population and involve masticatory muscles, TMJ, and the associated structures. It can occur as pain, TMJ sounds, or oral movement dysfunctions. Study evidence have summed up biopsychosocial etiology of TMD, with most studies assess psychological distress. But we know that there are positive psychological factors that have been associated with pain etiopathogenesis and even treatment approaches. That is why we want to examine the correlation between temporomandibular disorders severity, emotional distress, and psychological well-being, especially the eudaimonic well-being. We also want to compare the extent of emotional distress and well-being among individuals of differing TMD severity. We incorporated 873 young adults in the study, and we used 10 questions of FAI, Fonseca Anamnestic Index, to assess TMD severity. And DASS DAS 21 for the emotional distress. It has depression, anxiety, and stress scale. And also psychological well-being scale, PWBS, for the positive psychology or well-being. The PWBS has 6 subscales, which are autonomy, environmental mastery, personal growth, positive relations to others, purpose in life, and self-acceptance. And what we found out, we found that 40% plus has no TMD, 49% of the subjects has a mild TMD or MT, 10% with moderate or severe TMD. Among the subjects with pain complaint, the headache is the most prominent one, and also among the ones without pain, TMJ sounds is the prominent one. And we found out that distress has a negative correlation with well-being, which is also in concordance with many studies. We see in this study, we see that there is a significant difference in emotional distress and positive well-being among differing TMD severity. You can see there here in the table, people with severe TMD has more more distress than the one with no TMD. And also with the psychological well-being, no TMD has better well-being than the one with severe TMD. There are different relations of subscales of well-being to TMD. For instance, we see that personal growth here does not seem to be influenced by any or different severity of TMD. Why? Well, it will take another study to dig more, but it is interesting to dig more about this. Subjects with severe TMD has lower environmental mastery and self-acceptance. It seems that participants with moderate to severe TMD may have problems controlling their personal situations or their surroundings and accepting their functional, physical, and social limitations. From this study, we are interested more in developing the positive psychological intervention in, let's say, attacking the TMD of differing severity. That is all from my presentation.
Thank you, Dr. Carolina, for your interesting presentation. Now, any questions or comments from the participants or from the floor? Okay. Now, actually, I have one. It's very interesting that you use the eudaimonic well-being.
Yes.
Yeah, to relate that to the TMD severity. My question is, if I understand it clearly, the eudaimonic well-being is related to the purpose in life and so is which index or scale that you use to measure this?
Okay, we use the one that is the first when it came out. The one that is most prominent to be used is the RIF PWBS, Psychological Well-Being Scale. The one that we use has 7 rating scale. It has 18 questions with subscales. RIF from 95, I think that is the most used psychological well-being scale, and it's not been used in the field of dentistry yet, as I recall. So it's interesting to see whether there is a correlation, and if yes, can we use this in treatment?
I see, thank you. There's another question in the chat box from Professor Coleman Margaret. He said, regarding to the sample, where and how were participants recruited?
Oh, okay. Oh, I think shall I share screen again? I'm sorry. I don't know what I, okay, we recruited from university students. It is university students population. It is not patient population. From Trisakti University, we send out invitation, and the one that is and they applied to be submitted in this study, and then from the inclusion criteria, we got finally 873.
Okay, thank you for your presentation. Now we have to move on to the next one because we run out of time.
Yes, thank you.
Thank you. And the second one is me. I am Nipapon Shotima from Chulalongkorn University, and my study is oral health services during COVID-19 pandemic in Thailand. During the pandemic, Thailand has passed through several stages of the outbreaks in the 2020. The oral health services had been limited depending on the outbreaks and the government policy in Thailand. Therefore, our study aim to explore the oral healthcare provider response to COVID-19 situation between the lockdown period and the ease restriction period in Thailand. The methodologies. This study is an online survey research. The questionnaire comprised questions about behavior, level of concern, infection control practice in dental clinic during the lockdown and the ease restriction period was distributed. Descriptive analysis, Magma test, Wilcoxon silent tests were performed at the level of significance of 0.05. Now move to the result. Total of 406 oral healthcare practitioners, which are 382 dentists and 24 dental nurses from Bangkok and 4 regions of Thailand, contributed to the study. Among these participants, majority of 78% were female and 63% had more than 15 years working experiences. Now let's see the bar graph, show the response comparison divided into 2 domains. For the blue background, this one, show the service provided. We will see that the strict of patient screening protocol, waiting room management, and COVID patient referral system were higher during the lockdown periods, while both general and emergency treatment provided were lower during the lockdown periods. 78% of participants did not perform non-emergency dental procedure compared to the 10.3% during the ease restriction period. Now move to the other one, the cream background, show that during the lockdown period, a higher proportion of oral healthcare practitioners report that they always perform the infection control strategy, including using the PPE, such as face shields, N95 masks, isolation gown, and eye protections. They also use high power suction and a proper ventilation system in the clinics. And they're also providing the environmental disinfections. But surprisingly, only 50 to 60% report that they always use N95 masks, and the clinic had the proper ventilation system, even in the restriction period or the lockdown. All of the categories in this graph are significantly different between the 2 periods. Now, the conclusions. Overall, the oral healthcare services in Thailand were well managed in response to the COVID-19 pandemic. Additional training and protocol for dental practitioners may be needed to maintain the standard procedure of infection control as a universal precaution at all times. Thank you very much. Any comments or questions are welcome.
A very good presentation and need of the hour. That is management of COVID-19 patients, dentistry during COVID-19 pandemic. Can you hear me?
Yes.
Yeah. Now you spoke about the different services which is provided. What are the challenges that you faced while providing oral healthcare services during the COVID-19 pandemic?
You mean the challenges during the
Yes.
healthcare? Yeah,
Yes.
because in Thailand they have several states of the outbreak. Some states of the high prevalence or high infections of the disease. We have the lockdown, or we have the we mean the recommendation that the clinic have to close, or that the one that the challenge that the people cannot come to the clinic at all. But the other one is the ventilation system, because before the COVID-19 pandemic, at I think most of the dental clinic don't have the proper, the correctly ventilation system, like the proper air change, like 12 air change per hour or something, or the purifying system. So when the pandemic come in, the clinic or the hospital have to renovate during the lockdown to make the infection control is at meet the standard.
Correct.
Yeah.
Correct. And this was the common problem that we faced all around the world. That is the cross ventilation and change of filters. And the use of HEPA filters was a common problem which most of us faced all around the world. Even in India, we had the same problem. Can I add one more question?
Yeah, sure, you can.
Yeah. Correct. Now you were talking about the modification of the universal protection barriers and the PPE which was added on for assistance. What is your advice about the PPE? Do we need to continue wearing it all throughout as a universal protection barrier, or do you think that there need to be a modification?
As my study and my knowledge, I think we should continue recommend for the PPE, because and also to the assistant of other professional, not only dentists as well.
Correct. Okay. Thank you very much for the presentation. Any other questions?
No, I think. Okay, I will stop sharing screen.
Yes. Thank you very much.
Okay. Now I think we should move on to the next presentation, which is Dr. Mita Hesh. Yeah, from A.B. Shetty Memorial Institute of Dental Science. Yeah.
Yeah. Very good morning to all. This presentation, it's a clinical trial study of the effect of medicated toothpaste on oral health, comes from Nite University, which is situated in India, and my institution, A.B. Shetty Memorial Institute of Dental Sciences. After knowing the global burden of disease, 2015, which estimated that about 3.5 billion people worldwide live with dental problems, among the various oral hygiene methods, toothbrushing and herbal toothpaste plays a major role. The search between 2015 to 2021, we did a literature survey, and we found that when we did a search for medicated toothpaste, clinical trials on toothpaste, on PubMed, Scopus, and Web of Science, we found that there are only 96 results. And out of this 96 results, most of them were on fluoride, desensitizing agent, chlorhexidine, and remineralizing agents. Since there was no evidence regarding the effect of toothpaste on salivary total antioxidant, melanohaldehyde, and vitamin C levels in short-term, medium-term, and long-term use, we aim to study the 6 months follow-up or as an active control trial to analyze biochemical parameters of the oral saliva. In this active control trial, we recruited participants aged 25 to 50 years, fulfilling the inclusion criteria of not taking any medicaments, no history of any systematic illness, no history of radiotherapy or chemotherapy. And the study protocol and procedures were accepted by the University Ethics Committee and clinical trial registration was done. A voluntary written consent was obtained from patients. The WHO Oral Health Survey 2013 Annexure 1 was used to document the case history and intraoral examination details, and about 427 participants were enrolled, out of which 280 healthy subjects free from systemic diseases affecting salivary flow pattern were available for this study and for a follow-up of about 6 months. We again grouped them into two caries-free and caries-active patients, 140 each, and further divided into 4 subgroups of 3 groups of medicated toothpaste and 1 control group using a non-medicated toothpaste. The subjects who satisfied the enrollment criteria were provided with the commercially available non-herbal toothpaste and brush for a week's time, and this allows for an attenuation of the residual effect of the subjects previously using toothpaste and enables every subject on the same toothpaste background for a washout period. Later on, after a week's time, the collection of saliva was done. Early in the morning, saliva was collected 2 hours after brushing. 5 ml was collected in Tarson centrifuge tube, and the supernatant obtained was stored at -80 degrees centigrade for subsequent analysis. The salivary total antioxidant capacity was evaluated using the phosphomolybdenum method, and the melanohaldehyde was evaluated using the TBA-TCA method, and the vitamin C was evaluated using the DNPH method. The reporting guidelines were followed as per the stroke criteria. And the results, we found that the mean salivary total antioxidant activity and the vitamin C levels increased, whereas the mean salivary MDA levels decreased in the groups using the marketed medicated toothpaste over a 6 months period. Whereas in the control group, the mean salivary total antioxidant activity and vitamin C levels decreased and MDA levels were increased. After 6 months trial, it can be concluded that medicated toothpaste with herbal and Ayurvedic extract enhanced the overall health by increasing the salivary total antioxidant capacity, vitamin C levels, and decreased the MDA levels. The advantage of medicated toothpaste with herbal extract is the herbal component used in the study, which consists of products formed and found naturally in nature and have been used in food items that we regularly consume, and no synthetic chemical compound. And the herbal compounds used in these medicated products have been proved to have a medicinal property which is advantageous and even therapeutic to the bodies. The post-usage of medicated toothpaste with herbal extract and increased total antioxidant activity and decreased MDA and increased vitamin C levels can be directly related to the increase in the pH and improved gingival health in the patients with medicated toothpaste with herbal extract. Thank you.
Thank you, Dr. Mitra. The presentation is very interesting about the medicated toothpaste. We're waiting for the question, but I want to know the toothpaste is all marketed, or you just?
Yes, it's a marketed toothpaste, the toothpaste which is already in the market. We have a number of medicated toothpaste in the market, and I selected 3 out of it.
I see. Is there any fluoride ingredient in the medicated toothpaste?
Yes, the ingredients, they have the pudina, the lavang, the pepper, and a clove, and they have the natural herbal extracts. So these, I selected most of the toothpaste which have herbal extracts, and most of these condiments which we use in the diet, our regular food diet. In India, we have a lot of spices which we use in the diet, and which is supposed to improve our immunity and boost the immunity. And this is what is there in this medicated toothpaste, and that is how I thought it could be, because the toothpaste is something that we use for morning and evening 2 times. Early in the morning, we put it in our mouth, and late in the night, before going to bed, we put it in our mouth. Maybe there is some effect, and I thought, let me study using the saliva as a media to see the changes.
There's a question from the Professor Coleman that why use stops and not consorts in the reporting?
By use
Why you
criteria. It's an observational study. It's an observational study, basically. So the report, it's basically an observational study. So that is why we have used the stroke.
Okay. Yeah. Thank you very much, Dr. Mitra. Yeah. Now we move on to the next presenter. I didn't see Dr. Harsh Priya. Oh, yeah. Yeah,
Yes.
you're here. You can share your poster.
Sure. Okay. Can I start?
You can start now.
Good afternoon. Excuse me. The topic for my poster presentation is effectiveness of topical fluoride in prevention of radiation caries in adult patients of head and neck cancer. It's a systematic review and meta-analysis. So we know that the patients of radiation of radiotherapy in case of oral cancer, they have as a radiation caries as their late complication. So there is a method for preventing this where fluoride application is done. So we say that fluoride replaces the lost calcium hydroxide crystals owing to radiotherapy by forming the large hydroxyfluoride crystals, and this which increases the enamel resistance to solubility. There are some studies which state that fluoride alone may not be as potent in preventing the radiation caries as in combination with other methods. However, the other studies which say that the researchers used different formulations of fluoride, such as sodium fluoride or stannous fluoride or APF gel, or various forms like sodium fluoride mouthwashes, and for the prevention of radiation caries. So the aim of this systematic review was to find or pool the evidence of effectiveness of various topical fluorides in preventing radiation caries or the change in the bacterial growth in adult patients of head and neck cancer who were undergoing the radiotherapy. It was Prospero registered, and keywords and mesh were as per the PICO guidelines. And we did a search in PubMed, Google Scholar, and Cochrane. The participants were adult participants with head and neck cancer undergoing radiotherapy and thereby falling into the high risk for dental caries. The intervention was taken as the role of topical fluorides either independently or in conjugation with other agents in the prevention of radiation caries. And we compared it with the use of other formulations or placebo or a control group, or where there was no control group, they were also considered because there may be ethical considerations. So primary outcome was evaluated as prevention of radiation caries and also the change in the bacterial growth in saliva. And the secondary outcome was included as change in the salivary flow rate. So we extracted the data on various study characteristics like author, year, and study design, etc. And basically we saw that whether there were experimental groups including fluorides and control group, then interval between fluoride application, how much follow-up period was taken up to see the caries increment or reduction, the bacterial count, the change in salivary flow if it was included in the study. So, and the risk of bias analysis was done. The search strategy is not visible so much in the poster, but we took 7279 references from our first search, and 346 abstracts were screened, and 56 full text articles were taken into consideration. And finally, we considered 13 for the systematic review. Whereas the quality assessment of the included studies was done, we saw that the studies which were conducted in 1970s, 80s, and 90s, they were the quality was poor, whereas the studies which were conducted in 1998 to 2005 and 8, they had a good quality. And lately, the studies by Sohn et al., which is conducted in 2021, had a fair quality of in the quality assessment. The comparison of the study increment when we checked with sodium fluoride, which was used in combination with other fluoride preparations, we saw that in a few of the studies, the caries incidence as compared to the control group had either there was a reduction more than half or 2 to 3 times of the caries, where the fluoride increment was given in the range of the fluoride was from 1,65,000 ppm to 4,86,000, or even in one of the studies in 1994, where 8,73,000 ppm of fluoride was seen, was given to the patients. However, in these studies, the quality, since it was not of a good quality, so we cannot consider the exact amount of reduction, or cannot be the reliability factor is definitely there. Then we studied as the salivary flow rate also over time. So initially at baseline, if we see the salivary flow rate, which is of the stimulated saliva, of course, it ranged that it was from 1.1 to 1.73 ml per minute initially, which did reduce by one week post radiotherapy up till 2 months. And there are studies which have reported the reduction up till even 6 months, 6, 12, and 13 months also. So this was considered as secondary outcome, and the amount that the amount of decreased saliva was ranging somewhere from 0.1 ml per minute to 0.88 ml or 85 ml milliliter per minute, and this was mainly the stimulated kind of saliva. Then the comparison of caries increment with fluoride as an adjunct to remineralizing agent. In this, we did meta-analysis. However, we found only 2 studies. So in one, the fluoride was used, and other remineralizing agents such as chlorhexidine was used, or APP, ACP was also used. However, there was no significant changes that were seen in this study, in this comparison. And again, when the comparison of caries increment was done, where in one study sodium fluoride was used, and in another study sodium fluoride in combination with other fluorides, for example, stannous or APF gel were used. Again, in this also, caries reduction was there, but definitely a significant caries reduction was not there. And only 2 studies were there in both the meta-analysis. So we conclude in our study that use of fluoride as radiation caries preventive agent is recommended through the evidence gathered in this review. However, to delineate the exact formulation, as in how much dose should be given at what frequency, so that protocol is yet to be defined, and by conducting further more randomized controlled trials and more long-term follow-up would be required. Thank you so much.
Thank you, Dr. Priya, for your informative presentations. And I didn't see the question now, and we also ran out of the schedule. So can we move on to the next presentation? And my apology for Dr. Selena Garcia that I skipped her presentations. Now we'll give the floor to Dr. Selena Garcia. Yeah, you can share your screen now.
Pleasant afternoon, everyone. I am Selena Garcia, and I'm here to present our research on the prevalence of systemic conditions among Filipino older adults with periodontitis. Now, the reason why our research group wanted to look into this is because despite the vast and growing evidence that there is an association between periodontitis and various systemic conditions, there's actually very limited data of this association among older adults in the Philippines. Now, this research I am presenting is actually a sub-study of the Focused Interventions for Frail Older Adults Research and Development Program at the Institute on Aging, National Institutes at the University of the Philippines, Manila. And our participants had to be at least 60 years of age, and they were randomly selected from one of 4 geographical regions, which you can see here in Figure 1. And all these participants underwent a comprehensive geriatric assessment, which included, among others, an interview, laboratory, and physical examination. However, there were quite a number of dropouts, and by the time the dental examination was performed, only 316 got to complete such. We got to exclude from this study's data analysis those who were completely edentulous, those who only had 1 tooth, all teeth were root fragments, and those for whom periodontal assessment could not be completed because of complaints of pain during examination. And therefore, at the end, included in the study's data analysis were 183 participants. And if I may direct you to Table 1 here, we get to show the patients or the participants' demographics. Most of them, majority, 116 out of the 183, were in the young-old group, with a mean age of 68, and close to 40% were male. In Figure 3, we get to present the percentage distribution of the participants' periodontal status. And you can see that none were diagnosed with either clinical gingival health, gingivitis, or initial periodontitis. So all of the 183 participants had periodontitis, with 94.5 having the severe type, and the remaining 5.5% with moderate periodontitis. And these diagnoses were determined based on the 2018 classification of periodontal and peri-implant conditions and diseases. Now, we also got to investigate the prevalence of various systemic conditions among the study participants. And here in Figure 4, we get to list the systemic conditions alphabetically. And the top comorbidity was hypertension, and you can see that 62.4% and 80% of those with severe and moderate periodontitis respectively had hypertension. Other notable findings were the 18.5% prevalence of diabetes among those with severe periodontitis, and there were 16% and 30% of those with severe and moderate periodontitis respectively who were clinically obese. And then lastly, 13.9 and 10% of those with severe and moderate periodontitis respectively were frail. And therefore, data from this study show that the prevalence of various systemic conditions among Filipino older adults actually varies. However, our research group recommends that additional research on a higher number of participants be conducted, along with comparison of systemic conditions in Filipino elderly without periodontitis. Thank you very much for your kind attention.
Thank you, Dr. Selena Gracias. I'm just looking at the questions. There's no question right now. I have a question. From your study, what is the implications or recommendation from your study of the prevalence of the systemic conditions among older adults with periodontitis?
So you can see that there's a very high prevalence of periodontitis. It's 100%. Based on this study, we actually came up with a policy brief recommending that the Philippine government expand the dental health coverage of Filipino elderly. Well, actually not just Filipino elderly, but of Filipinos in general, so that we can prevent periodontitis in the older ages. Because at present, if you go and look at what is covered by the national health insurance, it's a checkup, urgent treatment, patient education. So no curative treatment. And then, of course, because of this possible link between the systemic condition and the periodontal status, then there should be like co-management in the sense that if once the patient has periodontitis, then we may have to refer our patients to physicians so that they can be managed accordingly, also for their systemic conditions.
Thank you. Actually, there's another question, but you can have a very quick answer. How you calibrated examiner to do the periodontal assessment during this study from Dr. Hu?
Okay. Thank you for your question. At the beginning, okay, a board periodontist, a board certified periodontist, got to conduct a training and then calibration with 3 additional examiners. So there were a total of 4 examiners, and there was a calibration session.
Thank you, Dr. Serena. Okay,
Thank
now
you
we
also.
move. Yeah, we move on to the next presenter, Dr. Kwang Trinh from Nikiata University. You can share your screen now.
Hello, can you see my poster?
Yeah, you can see it.
Okay, good afternoon, everyone. My name is Kaumya Tin, originally from Myanmar. Now I am working in the Nikiata University. Okay, let me start my poster presentation. My poster presentation is the Anticaries and Antimicrobial effects of school-based fluoride program in Myanmar. And so our study aimed to investigate the Anticaries effect of fluoride varnish application with the 3 months interval and fluoride mouth rinsing weekly on primary teeth, and also to evaluate their antimicrobial effects on cariogenic bacteria among the Myanmar children. So this study is a 6-month intervention study, was conducted in the 5 to 6-year-old 234 children, Myanmar children, and we allocated into 3 groups. In the group A, we provide the fluoride varnish application with 3-month interval. In the group B, they receive the FMR weekly, and in the group C, they receive no fluoride application. So as a result and discussion, at the baseline, there were no significant differences in both clinical and microbial oral health status. However, we found the caries rate test score were significantly associated with the caries prevalence and the mean DMFS in all age groups. So table 1 shows the comparison of 3 groups between baseline and 6-month follow-up. Here we can see that there were no significant differences in clinical oral health status between baseline and 6-month follow-up in both group A as well as in the group B. However, in the group C, we found the DS and also the DMFS were significantly increased within the 6 months. So our findings demonstrate the effectiveness of fluoride in caries prevention. And also we could say the children without any fluoride exposure may develop the tender caries within 6 months. Regarding with the microbial oral health status, here we can see that the plaque and the saliva sample of the dental care SM were significantly decreased only in the fluoride varnish group, not in the group B, fluoride mouth rinsing group. On the other hand, significantly increased in the group C, where is the control group. So this study showed that the fluoride varnish application at 3 months interval, we have the antibacterial effects on the mutant streptococcus than the other groups. It means the fluoride mouth rinsing as well as the control group. Table 2 show the comparison of changes between the 3 groups. The proportion of children who developed the dental caries were significantly decreased in both group A and group B, as well as the plaque and saliva sample of the dental care SM also significantly improved only in the children who received the fluoride application. So our study approved that the fluoride may partly contribute the antibacterial effect for the caries prevention. So as a conclusion, fluoride was approved to be the most effective in the dental caries prevention. Although there were no significant differences in clinical oral health data between fluoride varnish and fluoride mouth rinsing, we found the more favorable finding was found in the children who received the fluoride varnish application. Thank you very much for your kind attention.
Thank you, Dr. Quang Truong.
Yes.
Any questions from participants? Okay, I have a question.
Yes.
It's a participant who's in your study have the high risk of the dental caries?
Yes, according to my previous data, these children are the high risk than the caries children. Yes.
I see. So, as your conclusion, do you recommend that you should use the fluoride varnish instead of the fluoride mouth rinse?
Yes, from my study, we could say the fluoride varnish application with treatment interval is better for the high risk children. However, we have to consider about the financial effectiveness as well.
Yeah, I agree with you.
Yes.
Another question from Dr. Palini. The question is, how about baseline data among the three groups?
They are, as I already mentioned, at the baseline, there were no significant differences between the three groups in both clinical as well as the microbial oral health stages. Yes.
Okay. Actually, another question.
Yes.
But we kind of run out of time. Okay, very fast. Very curious, how can caries increment so significant in only 6 months? From Dr. Chu Yang.
Yes.
In the time frame of 6 months.
Yes.
Yeah, he said that it's very curious.
I'm sorry, what you mean that the caries was significantly increased? Caries did it?
He mean that only 6 months, how can you measure the caries increment that differently? I think he is questioning the time frames of the 6 months.
Yes.
Yeah.
Actually, of course, our study aimed to the more than 1 year, but according to the COVID-19 situation, we cannot proceed our study. So this is also our limitation. But within the 6-month study, that's why we analyzed not the DMFT2 level, we analyzed the surface level analysis.
Okay, thank you very much.
Thank you very much.
Now we move on to the next presenter, Dr. Quang Tran. Dr. Quang Tran, are you in this? Yeah, you can share your screen now.
Could you see my slide? Could you see my poster?
No, yes, now we can see now. Yes.
Yes, it's my honor to have chance to present my results about a barrier to access oral health care among HIV adults. The objectives of this study were to survey barrier to access oral health care service and to assess factors affecting this barrier among people living with HIV/AIDS in Ho Chi Minh City, Vietnam. Questionnaire that included 50 items regarding barrier to access oral health care were developed and validated, but which format anchor in ICCs were 0.89 and 0.94 respectively. The study was conducted in 2 phases. In the first phase, 399 people living with HIV/AIDS 18 years or older living in Ho Chi Minh City participated in the 4th seasonal study happening from April to June 2021 by responding anonymously the 15 items on the questionnaire. Then 30 of them who had high score of each barrier were invited to join the in-depth interviews for the second phase. The factors affecting them were interviewed by two trained reviewers. Finally, we obtained some following results. Firstly, there were 4 groups of carriers to assess oral healthcare support service among people living with HIV/AIDS in between cities. A cause, awareness, fear, administration, and access. Four main factors affecting them were stigma and discrimination from society, self-stigma, dental treatment cost, and complex administrative procedure. Moreover, we have the frequency of dental visits of HIV adult tended to decrease, especially there are 12.2% of the participants report that they had not seen HIV positive. Regarding to unmet oral health care needs, up to 41.9% of the sample study were practically met and 11.3% of them were totally unmet. In conclusion, the people living with HIV/AIDS were facing many barriers to access oral healthcare service in Ho Chi Minh City, and there were many factors needed to be solved by prioritizing oral healthcare policies for the special subject in the community. Thank you for your high attention. If you have any further questions, do not hesitate to let me know.
Thank you, Dr. Tran. If there's no question, we will move to the next presenter because we ran out of time and your presentation is very interesting. Thank you. Now move to Dr. Yushi Choi from Sun Yat-sen University. Yeah, you can share your screen now. Oh, Dr. Tran, you have to, yeah. Thank you.
Okay. Okay, can you see my screen?
Yeah, I can see it. You can, yeah. Perfect.
Okay. Good afternoon. I'm Yuqi Cui from Sun Yat-sen University. It's my great honor to participate in this conference. My topic is the association between adverse birth outcomes and dental caries, a systematic review and meta-analysis. It is well known that childhood dental caries and adverse birth outcomes are considered serious public health. And studies on the association between adverse birth outcomes and dental caries in children have shown conflicting results. So the aim of this systematic review and meta-analysis was to investigate the association between adverse birth outcomes and dental caries. In this study, we systematically searched articles in 4 electronic databases published prior to August 2021. The odds ratio or converted odds ratio and the corresponding 95% confidence intervals were processed. The certainty of evidence was assessed using the GRADES risk bias assessment tool. In Figure 1, a total of 3,727 papers were searched from the electronic databases and had searched. 33 observational studies met the inclusion criteria after screening. The report estimates indicated that children exposed to low birth weight or preterm birth did not experience higher dental caries in both primary and permanent teeth. However, in Figure 2, cross-sectional studies showed significant differences in dental caries between low birth weight and normal birth weight, yet no obvious differences were found for case control or prospective or retrospective studies. In Figure 3, subgroup analysis based on national income found significant differences between high-income countries and low and middle-income countries. in premature children with primary dental caries. It means that in high-income countries, PTB children experienced a high caries prevalence. In summary, our current study did not support that children with low birth weight had a high risk of dental caries compared with normal birth weight for both primary and permanent teeth. Children with PTB in high-income countries had a higher prevalence of primary dental caries. We suggest that further prospective studies should select appropriate sample size and adjust for confound factors such as age, oral health, and family finances, etc. Thank you.
Thank you, Dr. Yu Shishwal. Any questions from the participant? No questions. I have a quick one. Yeah, from your conclusion, the children with PTB in high-income country had a higher prevalence of the primary dental caries.
Yes.
It's kind of interesting. Do you have explanation for this? Or possible explanation?
什么? Okay, in some high income countries, they eat more
sugar, right?
Night milk frequently or eat more sugar.
Okay. Yeah. Thank you very much. Okay, now we move. Yeah, thank you. Now we move to the next presenter, Dr. Palini Desambunrat from Chulalongkorn University.
我要退出怎么退?
Yeah, you can stop share screen. Dr. Xu. Yeah. And Dr. Palini. Oh. Share screen again, please.
Okay, wait a minute, please. Okay. Okay, can you see my screen?
Yes.
Okay. Good afternoon, everyone. My name is Dr. Parini Desamurat from Chulalongkorn University. This poster reports on a project which addressed the issue of the lesion size specific associated with arresting of silver diamine fluoride. This research draws on the idea that silver diamine fluoride is a minimally invasive, non-aerorizing preventive treatment that arrested early decay. This study aimed to analyze 12 months in arresting caries of SDF applied among kindergarten. The method students aged 3 to 5 years with at least 2 carious lesions who consider as high risk and low and apply single annual application of 38% silver diamine fluoride solution. This study we use dopamine from the Australia in arresting cavitated dentine caries in primary teeth. The treated teeth were examined by an independent body examiner at 12-month follow-up. Arrested caries were defined as the treated surface having smooth and hard on probing, no sign of active caries or discomfort. The data were analyzed by descriptive statistics, chi-square head, and methodologies regression analysis to calculate the probability of arresting caries. The result, the study found that SDF shows potential as an alternative treatment for caries arrest in the primary dentition for community setting. If you see the pie graph diagram show that a total of 138 teeth, around 86% were diagnosed as arrested at 12-month examination. And the left bar graph show that lesion without proximal region had a higher chance of becoming arrested than with proximal region. Also in the light bar graph show that the region in anterior teeth with smooth surface and small size had more arrested than posterior teeth. And the table 1 showed that there were significant difference shown in the red value in the caries arrested rate of different position, p-value less than 0.05, lesion size specific, and size of lesion for bivariate analysis. And however, for multiple logistic regression, region size specific still significantly affected arrested cavity after adjusting for other variables with odds ratio 3.8. Conclusion, one important implication of this study is that the silver-diamine fluoride treatment were more effective in arresting caries on smooth surface of anterior teeth. Overall, we found that silver-diamine fluoride show potential as an alternative treatment for caries arrest in the primary dentition for community setting, and the region size as the one factor of the effectiveness of caries arrest by silver-diamine fluoride. Okay, thank you for your attention. Any question, please?
Thank you, Dr. Parini, for your interesting studies of SDF. If there's no question, we will move on to the next presenter. Dr. Mary Cherry Serrano. Yes, you can share the screen now.
Yes. Can you see my share
yes,
screen?
we can see.
Okay, thank you. Good afternoon. My name is Maria Cherry B. Serrano from Centro Escolar University, Manila, Philippines. The title of my research is Spit No Rinse Toothbrushing Technique Against Dental Caries Formation. This technique is to spit the foam of fluoride toothpaste and no rinsing after brushing, allowing the fluoride to have more contact time with the surfaces of the teeth, thus providing continuous protection. This study determined the effectiveness of the spit no rinse toothbrushing technique against dental caries formation, which was observed after 6 months of technique use. The study protocol was approved by CEU Institutional Ethics Review Committee. The subjects of the study were students of St. Jerome's Academy, ages 3 to 11 with no carious teeth, can spit and follow protocol. Out of the 219 total population examined, 35 caries-free students qualified, but only 24 were able to follow protocol up to the 6th month. Initial oral examination was recorded and served as a baseline for the study. Practical demonstration and drill on spit no rinse toothbrushing with fluoride toothpaste was done, and subjects were instructed to follow technique at home every morning and at bedtime for 6 months. Part of the demonstration was to show the correct application of smear layer of toothpaste among the toddler, while pea-sized amount was recommended for use among 6 years old and above. The drill was counted as the first day of the study. Then 6 months later, students were recalled and another oral examination was performed and recorded as the final result of the study. Findings showed that the 24 students, 23 of them continued to be caries-free after following spit no rinse toothbrushing technique. Only one participant developed dental caries on the posterior teeth. In conclusion, the result of the study suggests that the spit no rinse toothbrushing technique is a favorable measure against dental caries formation. Thank you.
Thank you, Dr. Sherry Serrano. I have just quick questions. How can you control the compliance of the participants of the spit no rinse technique at home?
Okay, basically, I started with the superintendent and then the teacher in charge, and then with the parents. From time to time, I communicated with the parents since most of them are doing their toothbrushing in the morning and, of course, in the nighttime. So I do follow up through messenger, through telephone call, or through text, just to remind that they should follow the protocol. Thank you.
Thank you. It's a lot of reminder to the parents. Yeah. Thank you.
Thank you.
If there's no other questions, I move to the last presenter, Dr. Huang La. Dr. Huang La from Odontomaxillofacial Hospital in Ho Chi Minh City. Dr. Huang La. Dr. Huang La from Odontomaxillofacial. Yeah, you can share your screen now.
Wait a minute.
While waiting for Dr. Huang, I encourage every presenter to visit your poster at the website, and so you can respond to all the questions that the delegates ask in the website as well. Dr. Huang, are you?
Yeah, I have a problem with my computer. Wait a second.
I am also sorry for the time management that make you all late for your lunch. Hope everyone's not too hungry right now. The technical team can you help with sharing his presentations or
All authentication permitted. Mr. Hamla, open your PPT first. Then go to Zoom. First open your PPT. Then go to Zoom. There was a green button. Share screen.
Technical team, do you have like a spare of the presentation to share?
No, ma'am, I don't have.
Or you don't have?
Mr. Hamla, first open.
Sorry, I can get the help from the technical team.
A technical team, you have his presentation with you, no? You can upload it and he can speak.
Because my computer can share the screen.
Please, the technical team, do you have the spare of his poster presentation?
Oh,
Ma'am, are they not able to share the poster?
Yes, he is not able to share the poster. If you can upload his poster, he can speak.
Okay, just give us a minute, ma'am. We will just bring it here and upload it. Give us a minute.
Yeah, the last speaker.
Okay, ma'am. Is this Latan Huang?
Yes.
Okay, give us a minute, ma'am.
Bấm cái desktop luôn rồi thầy, mà nó nó không có cấp quyền cho cái thằng Zoom này sao? Cái máy còn không cấp quyền cho cái thằng Zoom.
I think the technical team will take some time to get the file. And anyone who in this room, can you please share your video or yourself so you can take photo while waiting? Anyone? Thank you. Who will take photo for us? Okay, we will take photo by ourselves. Okay.
I
We
can
have
help you.
8 people. Okay. Smile. Doctor, oh, we have only 7. 1, 2, 3. Okay. Any one more question, one more picture. 1, 2, 3. Okay. Okay. Now we're just waiting. Nobody can contact with the technical team now.
He can present it without the poster. You can present your topic. Can he present his topic? Because we are going out of time.
Dr. Huang, do you want to present?
Yes. Could I present without the poster?
Yeah, sure. Everyone listening.
Okay. So sorry for this problem. Hello everyone. My name is Huang and I'm from University of Medicine and Pharmacy at Ho Chi Minh City. Today I will present to you the poster of our study about the validity and reliability of Vietnamese child oral health impact profile, COHIP. The child oral health impact profile, COHIP, is a tool to evaluate the impact of oral health on quality of life. But there's still no the standardized COHIP questionnaire in Vietnam. So the purpose of the study is to first to build a COHIP Vietnamese version of COHIP questionnaire, and second that to assess the validity and reliability of COHIP questionnaire among the 12 to 15-year-old children in Ho Chi Minh City in Vietnam. This study performed through 4 steps. Step 1, we will translation the English version COHIP of Broder in 2007 into Vietnamese. Step 2, we do the pilot study on 30 children. And step 3, after we have the standardized COHIP questionnaire, we do the cross-sectional study on the population of 853 children from 12 to 15 years old. And step 4, that we do the retest on 25% children from step 3 after 2 weeks. Then in step 3, we can calculate the Cronbach alpha, and in step 4, we calculate the ICC. And the result of this study that we built the Vietnamese version of COHIP questionnaire that have the construct and the content look approximately like the English version. And then we have the Cronbach alpha result of the COHIP Vietnamese version about 0.88, and the ICC, the general ICC of the COHIP Vietnamese version is about 0.88. So the conclusion that the COHIP, the Vietnamese version of the COHIP show high validity and reliability for children from 12 to 15 years old in Vietnam of Ho Chi Minh City. The COHIP should be used as an oral health related quality of life tool among Vietnamese children. So thank you for your listening, and sorry for the problem of my computer.
Okay, thank you very much, Dr. Huong. Now we also really late now. Thank you everyone for the participation, and hope to enjoy the rest of the conference. Bye bye.
Goodbye.
Thank you, Nipa.
Thank you. Bye bye.
Bye.
Bye.